Hello, everyone, and happy holidays. I'm Michael McNutt, Director of Education and Events for WEDI, and welcome to our special WEDI Spotlight, insight on the proposed prior authorization and attachments rule. It's my pleasure to introduce Robert Tennant, VP of Federal Affairs with WEDI.
Thank you, Michael, and let me add my warm welcome. Most of the country is under a freeze watch, but we've got two very hot rules to discuss today. So we are very excited to bring you this program, and we'll talk a little about WEDI and our processes, and then we'll get right into the presentation. So next slide, please. Many of you know this, but we started way back in the first Bush administration, where then Secretary of Health and Human Services, Dr. Lewis Sullivan, a practicing physician, brought in leaders in healthcare to try to find ways to make data exchange more efficient. And so we were born out of that working group for electronic data interchange, and we've been part of the discussion ever since. In fact, we were named in HIPAA as an advisor to HHS, and we continue to perform that role. Next slide. So how do we do our work? Well, we have a wonderful group of volunteers. We have work groups and sub-work groups. We have task groups, open public forums, conferences, and virtual spotlights like the one you're attending today. We track regulation and legislation, and we develop testimony and comment letters. And you can see here we have a wide array of stakeholders involved with WEDI, and that brings, I think, a very unique perspective to some of the key health IT issues facing the nation. Next slide. So how do we do our work? Well, a lot of it is done through our 18 work groups, sub-work groups, and task groups. And they are really the heart and soul of WEDI and our volunteer efforts. You can see here we have work groups that really span the entire array of health IT topics. And in particular, we're going to zero in on two of our sub-work groups. And that is, if you go to the next slide, we have an attachments sub-work group. And let me see, I don't know if if I can turn it over to Derwin Day, one of the co-chairs, he'll tell you folks a little bit more about this sub-work group.
Derwin, you can unmute. Doesn't look like he has audio, Rob.
Okay, well, I'll step in, and the group has not been as active in recent years because there hasn't been a lot of activity, but all that has changed. We've got really some wonderful industry experts to lead the discussion. So I encourage you, if you're interested in the attachments rule, join this sub-work group. They'll meet on a regular basis and go through the rule. We'll be discussing implementation issues and how to solve them. So encourage you to reach out to Sam Holvey at sholvey@wedi.org if you're interested in joining this work group. And if we go to the next, we also have a prior authorization sub-work group. And that's been extremely active in the last few years. The chairs are Heather McComas from the American Medical Association and Janice Bakos from Aetna. And it's a very lively discussion, as you can imagine, discussing many of the key issues facing the industry. And again, if you're interested in getting involved with this sub-work group, please contact Sam. And with that, we'll go to the next slide. And, we've talked about WEDI as the convener, and that's really our main focus with the industry. What we try to do is bring all of the key stakeholders together to not just identify the challenges facing stakeholders, but also come up with solutions. So I would encourage you, if you're not already a WEDI member, learn more about us at www.wedi.org. And the next slide is really going to highlight our role as convener. So we have a revised member position advisory process, an MPA. And really, that process has been put in place so we can pull together industry perspectives, in particular on requests for information and requests for comment, and on proposed rules like the two we'll be discussing today. And through conducting surveys, interviews, face-to-face and or virtual events, our goal is to come up with some consensus opinions on how WEDI should respond to the government action. And in this case, with both the prior authorization and attachments proposed rules, we will be conducting a lot of activities around this MPA process. So for example, of course, we'll be discussing each of these rules in the sub-work groups, but we'll also be conducting surveys in January. And I encourage you, if you see the survey come your way, please fill it out. It's very important. And if you're not the right person, please pass it on to that colleague in your organization. We also plan to hold live virtual events, 2 or 3. We're still in the development process, but it'll be multi-hour, and it'll be an opportunity for us to pull the industry together, discuss the key provisions in each of the proposed rules, and again, help us craft our comments that we'll then submit to the government in March. Next slide. And we really have a who's who of the industry on the agenda today. We'll kick off here with Alex Mugge from CMS. She'll be discussing the interoperability and prior authorization rule. We'll move over to Dr. Viet Nguyen with HL7, who'll talk about the fire components of the rule. Lynda Rowe from InterSystems will talk about the changes from the original rule, and many of you remember it came out in December 2020, and talk about the implications on the health plan side. And then we've added, because of the new rule, we're really delighted to have Daniel Kalwa from CMS talk about the proposed attachment rule. And Daniel has just joined the WEDI board, so we're really thrilled to have him involved. So with that, we can move to the next slide. I will remind you that this is a unique opportunity to ask questions of these leading industry experts on these rules. So please take advantage of the chat to either make comments or ask questions. And again, we'll hopefully have enough time to discuss these rules with the speakers. And with that, we can go to the next slide.
There are no more slides, Rob. We can hand it off to Alex.
Perfect. Thank you, Alex. And look forward to hearing your perspectives on this very important rule.
Thank you so much. Thanks for having me. And I think if the presenter can stop sharing, or maybe I can just take it. Nope. Okay. Yeah, if you could stop sharing, I will share my screen with some slides here today. Here we go. Hopefully you can see those all right. And thank you again for having me here today. It's really exciting to be joined by all of you, especially in the last couple of weeks here of 2022. I know a lot of folks are wrapping things up, but appreciate having this session so that we can share a little bit about our new rules and new policies. And if I do say so myself, I think it's a really exciting lineup. I'm not just saying that because I'm included in it, but to also hear from Dr. Viet Nguyen and Lynda Rowe and our own Dan Kalwa from CMS and my colleague within the Office of Burden Reduction and Health Informatics on this long-awaited attachments reg. I just think that there's a lot happening in the interoperability and health IT standard space these days, and it's so exciting to be part of this group and to be able to share some of this information with you. So without further ado, we'll kind of just jump into the presentation here. We like to talk at CMS about our path to interoperability and that there are a lot of steps on this path to interoperability. And with the proposed rules that we're talking about today, and specifically I'll talk about my proposed rule, the interoperability proposed rule, we're really continuing that path with these new policies and the guidance and the support that CMS is coming out with. We're going to share, of course, some of these late-breaking policies with you here today. But when we talk about our path to interoperability, we really talk about this as a journey. And a journey that doesn't really have an endpoint, but it's a journey that we're all on together in this path to interoperability. And it's a journey that will have to continue to evolve as technology evolves. So our policies need to evolve with that technology. And this will be a continuous cycle that we continue to work through together, again, as we get to that pathway to interoperability. So some of you may be familiar with two of our previous interoperability rules. There was the CMS Interoperability and Patient Access Final Rule that was published in May of 2020. And that was the first time that we engaged payers in this interoperability space. Historically, CMS has spent a lot of time and effort on working with clinicians and hospitals on interoperability and really taking a look at the interoperability from the EHR standpoint. But with that first interoperability rule, that's the first time that we engaged payers in this space by requiring them to build APIs using the FHIR standard. So we finalized two APIs in that first rule. And one of those APIs is going to be updated with the policies in this proposed rule that I'm here to talk about today. Then there was also the December 2020 interoperability proposed rule. That was also an interoperability and prior authorization proposed rule. That rule from December 2020 was never finalized. As many of you are aware, it was proposed and never finalized. And with our new rule that I'm here to talk about today, we are actually withdrawing that December 2020 rule. And so it will no longer be an effective proposed rule. You may note that several of the policies, or almost all the policies that I talk about today, are very similar to what was in that previous proposed rule. And in some cases, they're almost exactly the same. And I will highlight some of the differences as I go through, but it's important to note that if you look at the rule itself, in each section of the rule, there is a short description of what the difference is between that December 2020 rule and this new proposed rule. Some of the differences are minor and some of them are much more significant. And the reason for those modifications and the reason we're putting this out as a new proposed rule is that we've modified the policies based on the public comments we received on that December 2020 rule, as well as other advances that have taken place in the last 2 years. So we believe that these are much more modern and responsive policies in this new version of the proposed rule. And so I'm going to go ahead to the next slide so that I can share some of those with you right away. So on December 6th, we released the proposed rule with the short title, Advancing Interoperability and Improving Prior Authorization Processes. The comment period is open and will remain open until March 13th. So that's a 90-day comment period. And of course, we expect many of you will comment, but I'm going to encourage you to comment anyway, just to double down on that enthusiasm. We would love to see comments from everyone on the call today. So please submit your comments before March 13th. And of course, this rule demonstrates our continued commitment to interoperability and another step on that path or on our roadmap to interoperability. This also highlights our continued commitment to reduce burden in healthcare. This rule focuses quite a bit on the prior authorization process, which has historically been a significant source of burden for providers, as well as for payers and for patients. I think that it can be a burdensome process across the board. But with this rule, CMS is attempting to help streamline some of that burdensome process to save time for clinicians so they can put that time back into their patients. Now, I will be talking about prior authorization quite a bit through this rule, and I just want to note up front that when we talk about prior authorization in this particular rule, we are talking only about the prior authorization for medical items and services. This does not include prior authorization for drugs. Actually, I have in my talking points for this slide, no drugs, like it just doesn't include them. So I just want to call that out up front because we understand there are already standards and processes and timeframes in place for drug prior authorizations. And in this proposed rule, we're really focusing and doubling down on those medical items and services and prior authorization for those. I also want to note that while there will be some upfront costs associated with the implementation of this rule, we do anticipate that this proposed rule, if finalized as proposed, could save the industry over $15 billion over a 10-year period. And that's just based on the reduction in time spent on prior authorization alone. It's a pretty significant burden reduction over that 10-year period. On your slide, you can see a list of provisions, which I won't go through because I'm going to cover those in subsequent slides. But I do want to pause for a second to talk about the impacted payers of this proposed rule. As you'll see on the slide, this proposed rule would apply to Medicare Advantage, state Medicaid and CHIP fee-for-service agencies, Medicaid and CHIP managed care plans, and the qualified health plans on the federally facilitated exchanges. So the big difference between the December 2020 rule and this one is we are including Medicare Advantage. And this is in direct response to the public comments that we received on that December 2020 rule. Lots of folks want to see Medicare Advantage included. It is now included in this proposed rule. So that's a pretty significant difference. Another significant difference is that this rule also includes prior authorization policies for providers who were not included in the previous rule either. So when we talk about the policies for providers, we're talking about eligible clinicians, eligible hospitals, and critical access hospitals that are participating in the promoting interoperability programs. So more on that when we get to that slide, but I did want to highlight that because that's another major change from the December 2020 rule. Now, before I jump into the policies, I'm going to also say up front, the proposed implementation date for each of the policies in this rule is January 1st, 2026. And that is consistent across the policies, so I won't repeat that on every slide. But I do want to highlight that because I've already received numerous questions about this in the short time frame that the rule has been available. We've gotten comments on both sides, folks saying, you know, why are you waiting so long to implement this? And others saying this is not enough time. And I'm sure we'll get a lot of comments either way. But I just want to pause on this for a moment because we wanted to give more time because when we reviewed the comments on the December 2020 rule, we saw a lot of commenters asking for more time for implementation. We wanted to honor that request. We also understand that this proposed rule with requirements on providers means that the EHR developers also have to be involved in the process to help roll this out to providers. And that rollout it takes an extra step to rolling out, developing within the EHR and then rolling that out to providers and implementing that in their practices takes an additional step. And we want to make sure that there's time for that. I know that there are some who have said that this could be done sooner. You know, standards are ready, everything's in place. Let's do it because it's really, well, you know, again, I'm very biased here, but this is really important policy and really critical for reduction of burden in healthcare. But again, we decided to go with that 2026 date because we really want to make sure that this is implemented right the first time. Some of the policies in this rule require a bi-directional data exchange. So it's not enough that we're just making the data available, like in some of our previous APIs, the data is made available, folks can come and get it. In this proposed rule, there is bi-directional data exchange to help facilitate that process of prior authorization. That requires these parties to be able to interact with one another. And to do that, implementation has to be solid. So that proposed 2026 date is what we're looking at for now. Again, I'm sure we'll see lots of comments on that when the public comment period closes. So with that, I'm going to jump into the policies, but I also want to note that there are 5 RFIs in this rule. That's a lot to comment on. 2 of them are RFIs that were previously issued in the December 2020 rule, but are being reissued because folks wanted to comment on them some more. So lots of good content there. All of the RFIs tie back to the use of technology in healthcare and how that can get us to a better healthcare future state. So I also encourage you to take a look at those, and I'll cover those briefly in a moment. But jumping into the actual proposed policies of this proposed rule, the first is the patient access API. So in the interoperability and patient access final rule, again, that's the first rule, the rule from May of 2020, we finalized that impacted payers were required to build a patient access API that would allow patients to view their claims, certain clinical information, using an application of their choosing through fast healthcare interoperability resources, or a FHIR-based API. So that rule has already been finalized, and this policy is already in place, and patients should be able to access this data today if they are in one of the impacted, if they are enrolled in one of the payers that's in the impacted programs. In this proposed rule, we are proposing to expand on that, again, already existing API to include information about prior authorizations. So payers would be required to include information about prior authorization requests and decisions, and how long those decisions are effective. So patients have access to that information right from the application of their choosing, and they can get real-time, transparent updates. Well, not entirely real-time, but more real-time, transparent updates on their prior authorization status directly from that application of their choosing, using those FHIR-based APIs. So that is the first update to the patient access API. We're also proposing to require that payers would report metrics about patient use of the patient access API to CMS on an annual basis. And this is more for our purposes. We're not planning to publicly report that data, but because CMS wants to track the uptake of these APIs to ensure that we are engaging patients in their healthcare and see what more needs to be done in order to get some of that engagement from patients. The second proposed policy for payers in this rule is a provider access API. So we are proposing to require that impacted payers would implement and maintain a FHIR-based API to facilitate the exchange of patient data between payers and providers. This data would include all data classes and data elements included in the US CDI, which was previously adopted by ONC and we are now adopting for this use. Claims and encounter data, which would include cost data and certain prior authorization data. So this data that we're proposing to share with providers is exactly like what's being shared with patients through the patient access API, except that this excludes the cost information. Patients have access to cost information, providers would not. Otherwise, the data should be the same, and thereby allowing patients and providers to view the same information and better engage in a discussion about the patient's healthcare, because they do have access to that same set of data. The next policy for payers is another policy that was from the interoperability and patient access final rule. In that rule, we finalized a policy to require the exchange of data with other payers at a patient's request, and that was supposed to start in January of 2022. However, after we finalized that first interoperability rule, we heard from multiple impacted payers that because CMS did not propose a specific mechanism for the data exchange for payer to payer, that this was creating a lot of challenges for implementation, and that those challenges could lead to differences in implementation across industry, could lead to poor data quality and operational challenges, and also increased administrative burden. That's absolutely not what we are about. We don't want to increase burden, we want to reduce burden in healthcare. And so we took a look at this policy and we decided to issue an enforcement discretion, and we said we would not enforce that policy until future rulemaking. So with this new proposed rule, this is our future rulemaking. We are here, we have arrived. In this proposed rule, we are proposing to rescind that previous payer-to-payer data exchange policy, and we're replacing it with a proposed requirement for payers to implement a FHIR-based API for the payer-to-payer data exchange. Data that would be included in this payer-to-payer API would again be all the data classes and data elements in the US CDI, claims and encounter data, excluding costs, and prior authorization data. So again, same data being shared one payer to the other, that is also shared with providers and with patients. And in this way, patients are able to take their data with them when they move from one payer to another. One of the major differences in this policy that I will just quickly highlight is previously we did talk about this data exchange happening at a patient's request, and that's still the case with the new policy with the API, but we also talk about this a bit more as a data exchange that would happen at the time of enrollment. So we are really interested in seeing payers educate patients about the benefits of data sharing and try to get or see if the patients want to opt into that data sharing at the time of enrollment. So kind of better engaging patients up front in this process. It's just a little different approach that we've taken this time in the rule. Okay, so getting to the part that everyone is anticipating with prior authorization. Oh, and hoping not to skip over that too much. Sorry about that. So in this proposed rule, we are proposing to require that impacted payers would implement an API that would allow clinicians to do three things related to prior authorization. First, it would allow a clinician to query whether a prior authorization is even required for a particular, again, medical item or service. If prior authorization is required, it would too allow for the provider to determine what documentation or data is needed to submit the prior authorization. And then three, the API would help to actually facilitate the process of supporting the electronic prior authorization submission. And I say it that way, that it would help to facilitate that process, because it's not just the FHIR-based API that would be involved in the actual prior authorization, but in order for this API to be HIPAA compliant, it would also need to include the HIPAA Administrative Transaction Standard for prior authorization, which is the XBL 278. I have a slide in a moment that kind of shows how all of that works, but just keeping in mind that while this is the prior authorization API, it also must work in combination with those standards to ensure that it is a compliant transaction. So that API is just a piece of what we are proposing to streamline the prior authorization process. We know that technology alone is not going to solve our prior authorization challenges. We also made several proposals in this rule that are non-technical in nature, but we believe will help to support a better prior authorization process of the future. So the first is that we are proposing to require that payers send a reason for denial when denying a prior authorization. And it's important to note that that reason for denial should be sent regardless of the mechanism used to submit the prior authorization. So if it comes through the API, great. If it comes through another mechanism, also great. But the payer, if they're denying it, has to send that reason for denial, again, regardless of that mechanism. And that's to help with providers having hopefully a more successful resubmission. If they better understand why the prior authorization was denied, they have a better chance of resubmitting that prior authorization and getting a different outcome. The second non-technical proposal that we have for prior authorization is standardizing the prior authorization decision timeframes. So what we have proposed in the rule is that urgent decisions would need to be made within 72 hours of the prior authorization request, and non-urgent or standard requests would need a decision within 7 days. We did receive comment in the December 2020 rule asking for much shorter timeframes, but this is our starting point, 72 hours and 7 days, and we'll see what comments we get back. We do seek comment on additional timeframes in the proposed rule and look forward to reading the comments on those. And then finally, we are proposing to bring even more transparency to the prior authorization process by requiring payers to report certain metrics about prior authorization on their own websites. So they're not reporting that to CMS, they'd be reporting it on their own websites, and these metrics would include things like how often a prior authorization is approved, how often it's denied, number of prior authorizations that are overturned on appeal. That type of metric reporting would again go directly on the payer's websites to bring more transparency to their own prior authorization policies. Now, before I move on, this is all the policies proposed for payers in this proposed rule. And I have a few more slides here, but I want to pause here at this point in the presentation to say, we know that these policies will only apply to those programs that I listed previously, Medicare Advantage, the Medicaid and CHIP, fee-for-service and managed care, and the QHPs. But we also know that some of the parent organizations that are in those impacted programs have other lines of business, like commercial employer-sponsored plans, other lines of business for which they could also apply these policies. And we do encourage payers to the extent possible that they roll this out for all of their lines of business. And we at Medicare Fee-for-Service are looking to do the same. And in that way, we are attempting to lead the way in some of these policies by looking at what implementation looks like in the Medicare Fee-for-Service program. So we truly believe that these policies will help to streamline prior authorization and make for a better healthcare future state. And we would, we really encourage payers to think about whether they can implement these for their other lines of business as well. So like I said, that was all the proposals for payers. Now I want to take a moment to talk about our proposals for the impacted providers in this proposed rule. To ensure the adoption of this critically important prior authorization API and to really round out this prior authorization process, it's not enough for a payer to build an API. We need to also see those providers coming in using that API for prior authorization. So to help achieve that, we are proposing a new measure in the Promoting Interoperability programs that would require eligible clinicians, hospitals, and critical access hospitals to report on the unique prior authorizations that are requested using the prior authorization API, using data from their certified EHR technology. So again, in this way, really rounding out that prior authorization process, really making sure that both parties are coming to the table with this API and helping to facilitate electronic prior authorizations. This is the slide I spoke about just a moment ago. This diagram that demonstrates how on the payer side, we have the FHIR-based API with these implementation guides listed. I'll talk a little bit more about the implementation guides in a moment. You got it on the payer side and on the provider side. And in between, you have the X12278 transaction, which is, again, what helps to make this a HIPAA compliant transaction. So just a reference here, and there's more about this actual diagram in the implementation guides themselves. So talking a little bit about the standards for these APIs. We are proposing certain changes to the technical standards that would be for these APIs. I got a couple more slides that will show this a little bit more clearly. But we wanted to clarify, I guess, some of the ways that we are requiring certain standards for the APIs, and then other implementation guides that we are not requiring, but we are strongly recommending for the implementation of these APIs. I think it's actually easier if I go ahead and go right into the slides here itself with the visual. So these are the proposed required standards for each of the APIs that I've listed. We've got the patient access, provider access. We also have the provider directory API, which was finalized in the CMS interoperability and patient access final rule, the May 2020 rule. But we included this here because we wanted to clarify the required standards for that API. And then we have payer-to-payer API and also the prior authorization API. So again, these are the required standards. These are standards that have been adopted by the Office of the National Coordinator, or ONC, under their regulatory authority, and we are pointing to those regulations in our proposed rule, so thereby working with our colleagues at ONC to make sure that we are requiring the same sets of standards for our APIs. And then on the second slide, these are the recommended implementation guides for each API. We did not choose, unlike the December 2020 rule, I should note, we did not choose to propose to require these IGs at this time. Now, there were lots of reasons that went into that decision, but we make it very clear in the proposed rule that at some point we may propose to require these, but at this point in time, we weren't ready to do that. And that was for our own reasons because of some of the challenges with regulating standards as they are being implemented and updated. And so again, at this time, these are recommended, but they're really super duper extra strongly recommended. That's not a rule term, but I will just say super duper strongly recommended. And again, we may propose these at a future date. So I think it's wise for folks to reference these as they're looking at the implementation of their APIs and their programs. As I mentioned, I think I'm out of time. So I'm going to run through these next ones just real quickly because I would love it if we could get a couple of questions at least. There are several requests for information in the proposed rule. These two on this first slide were previously issued in the other proposed rule, but commenters overwhelmingly asked for more time to comment on them. So we are reissuing those. If you've already commented on them and you're done, you've said your piece, you don't have to comment on them. I mean, you really don't have to comment on any of them, but you know, this is just another opportunity for people to say a bit more about what they didn't have a chance to say the first time around. So that is accelerating the adoption of standards relating to social risk factor data and the electronic exchange of behavioral health information. Again, very, very complex topics here, but both related to the use of technology to support a better healthcare future state. On this next slide, we have the 3 RFIs that are new to this proposed rule. That is improving electronic exchange of information in Medicare fee-for-service, and advancing interoperability and improving prior authorization processes for maternal health, and finally, advancing the Trusted Exchange Framework and Common Agreement, or TEFCA. Again, all of these RFIs, while they're on very, very varied topics, all relate back to the use of technology and related to these topics and how to advance healthcare using technology. Here's just a quick slide with some helpful resources for folks, including links to those recommended implementation guides. Great reference material here. And then how to comment. And I keep forgetting that I need to update this slide with the date. So the comment period does close on March 13th. Please keep that in mind and consider commenting if you are able or contributing. I'm sure that we will certainly submit a comment. So we look forward to reading those after March 13th. And thank you very much for your time today. I'm going to stop there and see if you all have any questions.
Thank you, Alex. Yeah, we've got a few. I'll run through them quick. We'll also have some time towards the end of the program, I think, as well. But first question is just to confirm that qualified health plans that are on state-based exchanges are included under the rule?
The plans under the state-based exchanges are not included.
Are not.
It's only the federally facilitated exchanges that are included.
Gotcha. Great. We had Kalwa, Viet and Michael say thank you for addressing the concerns that we had with the payer-to-payer data exchange. Terry's asked a question. I'll let you weigh in now, but we may revisit the question after Dan speaks. And that is, obviously, there's a lot of synergy between prior authorization and attachments. The question is, there are different standards, there's different requirements. How will the two be harmonized?
So this might be a good one to wait until after Dan speaks, but I believe, I'm not sharing my screen anymore, but even as part of that diagram that I had shared, it does demonstrate how the X12278 fits into the prior authorization API. And it also shows an option for attachments, which Dan will talk about the actual standards being proposed for attachments. But I think that it still works together very well. And I think it all sort of accounted for as the implementation guide for the prior authorization support implementation was considered. So we can certainly revisit that, but I think you'll see that it fits together very nicely.
Excellent. And I know there's been some discussion in the chat, of course, about the implementation guide question. I think you covered that. Richard asked to go back to the resource slide, but we'll send everybody the slides, so you'll have that opportunity. With that, I think, Alice, we want to thank you very much for that. I know it's a very exciting time at CMS, a lot going on. We appreciate you taking some time out. And we'll switch gears and turn it over to Dr. Viet Nguyen, and thank you so much for joining us today.
Well, thank you very much, and thank you to Weedy and the leadership for the opportunity. This is really, hopefully, going to be very informative for everyone, and Alex really set up the policy parameters around this discussion. And my hope for this next session is to give you some details for those unfamiliar with FHIR and the implementation guides, what we have done as a community to help develop guides and to test them and implement them to support these policies. I really like Alex's notion of a journey, and Da Vinci, you can think of them as a group of the pioneers trying to help blaze the trail to go further forward in interoperability. So for those unfamiliar with Da Vinci, we are a FHIR accelerator developed and governed under the oversight of HL7, and we have really broad participation from across the industry, from providers, payers, and vendors. And it's these folks who have invested time and energy, along with a greater community, in developing these guides and testing them out. I think it was really important to call out how CMS and the proposed rule had listed FHIR under the current certification rules and then provided recommendations to guides, because I believe it does give us the level of flexibility we need to continue to advance on the foundations that FHIR provides, but to continually advance the guides so that we improve interoperability and address needs and concerns that develop when we go into production, because you can do our best to develop these guides and test them, but going into the real world, we find places where they need improvement, and the standards process allows us to do that. This is a list of guides that HL7's Da Vinci project has been working on over the past 5+ years, and I've circled the guides in red that relate to this rule, and we'll be highlighting a number of them. So first, as mentioned, is member attribution. So this guide is related to the need to identify a list of patients. Initially, we directed this guide to focus on risk-based contracts, but what we realized was that the use of a member list or a patient list is done frequently across healthcare for doing anything related to population and exchanging population data. So we have advanced this member attribution implementation guide and have put it back into ballot, a version 2 that is currently in ballot now, and continue to test it. And the goal here is for us to establish an attribution list or a patient list between a payer, or we call them a producer in this setting, and a consumer, such as a provider. And that list, we know, has to be managed and maintained because individuals go in and out of contracts, and lists of patients for whatever purpose they're used may change over time. The first version of our guide that's published allowed us to establish that list, create that list, and then the current version under ballot allows us to have a process to update that list and add and remove members in that list and maintain it in real time so that it can serve the purposes of information exchange. Very importantly along the way is that we have tested the use of this list for exchanging quality measures, which we often do in patient lists, as well as looking to have our other implementation guides in Da Vinci also utilize this list for data exchange in combination often with bulk data as well. So we think of this as a foundational function for FHIR and for interoperability and data exchange when it comes to population data. As Alex mentioned, there is the payer data exchange, and since that initial patient access API rule, we have taken the feedback and have gone to address a number of things in payer data exchange. We are finishing up the ballot reconciliation for the guide and look to publish it in the very near future. But the significant updates to the guide are the support of that prior authorization status that can be returned to the patient through the patient access API, as well as clearer technical guidance for the exchange for payer to payer, and in particular, the ability to operationalize from a technical standpoint the patient's, the member request or authorization to get data from their old payer to their new payer. And we have developed in the guide, as well as tested the notion of using both the OAuth approach, or the kind of smart on FHIR approach from the new payer to the old payer, as well as the approach of using mutual TLS to do member matching, and then establish a way for us to send large volumes of data between two payers. So this is kind of a summary. Each of these will have a summary slide of where we are and where we look to have support and participation by the community. So this the payer data exchange can also be used to support the provider data exchange. And actually we tested that back in 2020 and had a whole demonstration and presentation for the HIMSS conference that we ended up doing virtually. So just a little details of the payer data exchange. Essentially, payers get data, both clinical data as well as claims data, and the payer data exchange allows the payer to share that data under the requirements of the rules, that clinical data under US core data for interoperability, both to the provider through the provider API, as well as to other payers through the payer-to-payer data exchange, as well as to the patient for the patient access API. What was really useful, and it was asked in the chat, the two slides that Alex showed, the second one around the recommendations is kind of a mapping a slide that shows how CMS named a set of APIs, the patient, provider, and payer-to-payer APIs, and how these are supported by these IGs. So it's really important that they're not a one-to-one match, and that cross mapping will help you understand which of the Da Vinci Fire guides will support the specific named CMS APIs. Again, this was shown earlier, and this is kind of an overview of the 3 guides that support the prior authorization burden reduction. The first is coverage requirements discovery, and I'll call that CRD. Second is documentation templates and coverage rules, which is DTR. And the last is prior authorization support. As mentioned earlier, the prior authorization support was created and utilizes an X12278 mapping to have a fire representation of the 278 payload so that we can maintain that HIPAA transaction. And when this was first created, we didn't have a 278 requirement yet, but we also have the approach for supporting the attachments as a fire bundle as well. In CRD, I have a number of slides, but the bottom line for CRD is to close the information gap for the provider when it comes to ordering a service and knowing whether or not that service requires a prior authorization. So the key is to close that information gap, and where that burden is actually occurs is the fact that the providers don't know, and so they have their back office having to find that out, and then the patient may have left before information was gathered. So this initial CRD allows us to take the patient's coverage data, their payer data, and what is being ordered by the provider, and then sending that information to a payer's endpoint and returning a information about whether or not prior authorization is required or additional documentation is required. And when it is, we maintain the workflow and allow the provider or their back office to execute on an application, and that application is the DTR. But really here is just a workflow. We'll be sharing these slides so you can get the details, but the key points again are putting this into the workflow, so it's not just you're utilizing the important time you're with the patient to make sure that this information is getting gathered, knowing that a prior auth is needed, and getting that initiated as quickly as possible and filling out that information so that there's no delay in patient care. So the second part of the second guide related to this burden reduction is this DTR guide, which lays out a process for launching an application or functionality that could potentially be developed within the EHR to utilize information from the payer. The 2 pieces of information are a questionnaire, fire resource, and a set of a script, essentially called CQL, that identifies the data that the payer needs with respect to the service that's being ordered. The payers define that like they do today in forms, and we use FHIR to go out and retrieve the structured information from the EHR and render it to the provider to review it, and for them to add any non-structured data as necessary. The burden reduction here is that task of knowing what do I have to document. Again, that's often having to be done in a portal or looking at a payer's website, downloading a form and filling it out. This closes that information gap by having the payer let the provider know what's required, and then utilizing the FHIR and interoperability capability to retrieve that information, because that's burdensome too, is filling out those forms and knowing where. And so utilizing the questionnaire and the CQL reduces that burden. We recognize that some things may not be available at that time. So we've also added functionality to put this into a alternate flow if we need some support from the back office, or additional labs may need to be obtained, or other studies with respect to that documentation requirement. By completing this as early as possible, or as soon as possible, when the patient is there, we look to reduce the risk of patients getting lost, the work getting delayed, and patients having delays in services that their providers feel that they need. So again, these are details I won't cover too much here, but the key here is really reducing the burden of data gathering and making sure that the data supports the prior authorization so that the payer has the information they need to adjudicate the prior authorization and hopefully get it returned as quickly as possible and avoid delays in patient care. The third part of the process is to take that information that was gathered, that clinical documentation, and then submit it to the payer in order for them to adjudicate the information. The benefit of this guide is to put it within the workflow as well, and to, in time, we believe, get a real-time or near real-time adjudication of that prior authorization request, because now payers have structured data, not PDFs that someone has to read, in order to adjudicate the prior authorization and return the response. And we have also put in the guide the ability to take the required 278 data and package it up so that if there needs to be an intermediary that does the 278 transaction, they can take that data and do the transaction and send it to the provider. But we've also been very fortunate to have applied for and received an exception from CMS in order to do production level implementations of the guide, where the information is sent as fire to fire with the 278 data, but without the need to do the actual transaction. So a couple of our members, or a few of our members in the Pacific Northwest, Cambia and Multicare, have implemented this and this past fall. So we can share some information about that. But the benefit here is also reducing burden by minimizing the need to manage the prior authorization process through portals, as providers often have to do, and especially managing multiple portals for multiple payers. So we are currently under ballot reconciliation and look to finish up ballot reconciliation and publishing the guide early next year. So there are a number of technical benefits to these guides. Primarily, it's standardization across payers and providers, so that one payer has a method that's standardized for all the payers they use, and the payers have a standard process for working with the multiple providers that they work with. We also are supporting the use of more and more structured data via FHIR, which is a huge benefit. We are putting a common workflow expectations on both the payers and the providers so that we have consistency there. We are also addressing a frequently brought up concern from providers about the kinds of information payers are asking for, because FHIR can ask for very granular data like specific labs or broader data like certain documents. This will hopefully address some of the concerns about knowing what needs to be submitted to the payer for a given prior authorization. And the burden reduction is a huge part of this. The reducing the need for gathering, identifying, and submitting data that payers request when it comes to prior authorization. And my personal hope is that as we have more and more of this structured data, we'll be able to automate more and utilize more innovative technologies for adjudication, like machine learning and AI, that we have to start with some structured data, but in time we can do more of that and hopefully further reduce the burden for providers. And this is a benefit for everyone, really. For patients, we hopefully will have more and more of the care that they need getting authorized more quickly. We have many stories of patients having surgery scheduled, and as the day is approaching, they're still waiting for their prior authorization because it's information is being passed back and forth in non-standard ways. For providers, standardizing the approach so that with all their payers, it's the same kind of data via FHIR that they can submit for prior authorization, as opposed to unique forms that they have to keep track of or by using portals. And then for payers, improving the documentation quality and the quality of the data that they're getting in order to adjudicate these prior auth processes. And then this isn't in the proposed rule around prior authorization, but I did want to mention it because with Dan Kalwa coming up and talking about attachments, recently, just early this month, HL7 sent a letter to NCVHS having seen that there was an attachments rule in OMB regarding attachments and FHIR. We noted in the rule that of course, we didn't know whether or not fire was going to be mentioned in the proposed rule, but that we wanted to call their attention to that, the updates and advances that we had made in the clinical data exchange implementation guide that we feel could support the use clinical electronic clinical attachments as defined by CMS. And CDEX was noted in the proposed rule itself, and we'll leave that to Dan to describe. But we wanted to highlight what CDEX was, which is a process by which payers and providers can exchange clinical information to support clinical data for claims, post-payment review, and additional data for activities like prior authorization, quality, and risk adjustment that might not be gathered when they use our primary implementation guide, like the burden reduction guides that I just mentioned. And so this implementation guide is currently under ballot reconciliation and should be completed really soon and be published in January. But we've actually added some additional functionality to support unsolicited attachments, as well as supporting the ability for payers to send providers that equivalent of the form, that the DTR approach, where we can gather information via FHIR as well, again, in order to reduce the burden of finding and submitting data. But really, the approach here is that a payer would, from the requested attachments, send the provider a request that had a list of data that they wanted to request, whether they be documents like histories and physicals, labs, or studies. And then the provider, could review those and fulfill them after review, or using pure FHIR and high trust relationships between the payers and providers could just return all those requests automatically. So we have some of our payer provider members in DaVinci already looking at doing that. But this approach allows the providers to review the request in advance, but use FHIR to fulfill that request. We can also use this to, oh, sorry, I thought I had another slide, sorry. Fulfill the gathering of the data in advance. So one example is when maternal fetal medicine providers see a high-risk pregnancy patient, they are often asked to fill out forms by the payer to submit with their claims and kind of establish a high-risk pregnancy case. And so CDEX can support the collection of that data and ultimately building templates to support the unsolicited attachments as well. And we've had a lot of support from our members around the use of FHIR and CDEX for sharing this information. And so we, as part of our work in DaVinci, survey our members at the end of each year to see where they are in adoption of our guides. And as you can see here, clinical data exchange, a large number, the third out of all of our guides have been identified by members as even being adopted by a number of them, but a large number are planning to adopt it. Not all members do these guides apply to, so keep that in mind as you're looking at this, but this gives you a sense of commitment that the DaVinci members have to adopting our guides after they have invested time and efforts to support the community in developing them. And so that's kind of the summary of the majority of the guides that are referenced in the proposed rule. There are some that I didn't mention, PlanNet and Formulary, that we've discussed before, but we invite the community to come participate, learn more about our guides, come to Connectathons. We have a wealth of information available for folks from analysts, developers, as well as kind of executive level summaries as you need. So we invite you to come participate with us. You can find information at confluence.hl7.org that will lead you to the DaVinci homepages that has just a ton of information. So with that, I just want to thank again Rob and Weedy for the opportunity to be here. And if there's time, I'm happy to take a question, but I'm happy to also just stop here and try to address questions at the end.
I think we have a couple of minutes for questions and excellent presentation. I just wanted to mention, well, thank you to Josh and Leslie and Alex Goss for including some great resources in the chat. Terry asks a question. I know it's sort of involved with what we talked about earlier, but the idea is, we can still use the 278. Can you talk a little about how that fits in with the DETR process, especially with the attachments as it is?
Yes, so I've often looked at, and for those who are X12 stalwarts, you can correct me, but the X12 transactions as both a transport method, so the truck that carries the cargo and the cargo itself. And so the way we've looked at this is that the clinical data can be packaged in a number of ways. In the past, you had text documents or PDF. Then there was a recommendation at the time in 2016, I believe, around using CDA. The notion here, though, is that we could use FHIR as the method by which you gather the data and create a FHIR payload. And then we would be working and have worked pretty well with X12 to also include the X12 data for these transactions to support the transaction itself. So I think we can harmonize the approach of using a combination of X12 and their payloads, as well as FHIR to create the payload content, the clinical content. So I think that we do have an approach to have them work harmoniously together. And that's in the CDEX guide with respect to the unsolicited attachments. And it's in the prior authorization support guide with respect to how we support the 278. At the time, we didn't have the 275 defined yet, so we'll be looking at updates to our guides to reflect those as well.
Excellent. We do have a question from our incoming board chair, Ed Hafner. Can you provide a little more insight on the past subscription to receive prior auth status as opposed to specifically asking for PA status?
I'm not sure about the word subscription. I believe that the prior auth status, at least for the patient access API, and I will double check right after this call. I think we have it in the that can support the provider access API. We have that status information, I'll say, because I can't name the specific resource at the moment, as part of the payer data exchange, the PDEX IG. So the notion that the patients can get that status via the patient access API and the providers could get that through the provider access API. So I'm not sure what the question is around subscription. So if you want to put that in the chat, I'll try to.
Okay.
As well.
Perfect. And with that, I think I want to thank you again, Dr. Nguyen, for your expertise. And we are going to move to our next speaker. It's a pleasure to introduce Lynda Rowe from InterSystems. Lynda is a very active WEDI member, and in fact is now a co-chair of our health equity work group. So thank you, Lynda, and thank you for your support of this WEDI program.
Oh, thank you so much to WEDI. This has been our first year as members, and I have to say that it's just been a great experience for all of us at InterSystems. So, great team. I want to thank Alex and the CMS team for all the work that they have put into this, to Viet and the Da Vinci team. We spend a lot of our time supporting the work of Da Vinci, and thanks to Dan. So we're thrilled to be able to be here and to sponsor this. So what I'm going to do today is I'm not going to actually give you new information. I'm just going to give it to you in a different lens, because what often happens is we are asked over and over. So we've already implemented patient access APIs. So what net new? What are the new things we need to think about as we, move towards 2026. So I am not the expert, but, reading through the rules and trying to think, what are the difference between what has been implemented and what is being asked. So I'm going to spend some time quickly going through that. So I've sort of jumped over, 9123, because a lot of what was in this proposed rule obviously was in some part in the burden reduction rule in 2020. So again, I'm not going to go through this because Alex covered this pretty well in terms of, who's subject to the rules. I am not going to talk about the provider side of this. I know that's net new and it's around promoting interoperability, and there will be things that will need to be done, as she said, on the provider side, but I'm going to focus on the payer side because largely this is where the effort was. So let's look at patient access APIs. So if you think about it, the big difference is adding in that prior auth request and decisions, right, into that patient access API, with a note of being within 1 business day and with that new implementation date of January 1st, 2026, same set of standards. And I have to say, for those of you who have read the rule, or those of you who haven't, Table 10 is a great reference because that's where CMS goes through all the standards to support these implementations. So really helpful to look through that because it talks about standards and recommended implementation guides. And then again, as Alex said, there's sort of new policy around patient access APIs, and those are the payers to annually report patients who are transferred, data transferred through the access APIs, and then the unique patients who are transferring data. And I think that's a great metric and something that we're all interested in as an industry to see how this is being the uptake, across membership. Brand new provider access APIs, although as both Viet and Alex says, the same set of data, the same implementation guides, the same set of standards, the consistency is great to see that coming from rule or requirement to requirement. So again, big difference here, obviously, for claims, not including the cost information and then adding in the prior authorization status report above and beyond that clinical and claims data that was in the patient access APIs. Same set of standards that were required as part of patient access APIs, although I should have highlighted this, bulk fire is net new in this rule. It certainly was mentioned in 9123, the burden reduction rule, but so payers, that's the next new thing you're going to have to think about in addition to adding in the prior auth data. And then again, PDEX implementation guide is new versus what was in the 9115 rule. So both payers and folks like us, vendors, technology vendors that actually have to help our customers and those in the market interested develop this. That's what we focus on, is what is new, what are those net new things that have to go out in product. And then again, there are some additional policies. So I talked about not providing, remittances and cost sharing, the attribution process, and Viet talked about the IG that's been developed through the Da Vinci project to do some of the attribution, a method to allow opt-out of data sharing, and then the documentation that has to be available for providers so that they know how to access those APIs through the EHR. And then, as Alex said, the original peer-to-peer exchange was rescinded. And again, I know I saw it in the comments, but I'll also say thank you to CMS for listening to the industry in terms of the standards and what was needed. So a lot of stuff is new in terms of what payers were planning to do and what is required in January of 2026. So originally it was just sharing that US CDI data set, that clinical data, but this new peer-to-peer exchange will have claims data again, except for remittances, cost sharing information. It will add the prior auth data stream. It is now going to have a standard using FHIR and the FHIR Core IG. There will be a provision for multiple member data exchange. So we talked about bulk FHIR being there. And then again, at least a suggested set of implementation guides that Viet talked about. So PDEX, the Karen Alliance Blue Button, and then the PCDE for prior authorization status. Although I know that there is conversation going on within DaVinci about that. So the other requirements is an opt-in requirement. So that's a little different, right? Affirmative consent. The new payer has got to identify any previous or concurrent payers. So making sure that they know who the previous payer is and who the concurrent payer is, and then requesting the data from previous or concurrent payers if the member has opted in and they have identified that past or concurrent payers. And I know what I was sort of surprised at in reading the rule, though, was that there are some actual timeframes around doing this, that CMS is looking to make sure that as members transition, that there's a time frame and a process for making sure that the data gets moved over. And then, the prior auth API, again, all of it net new. I think Alex and Viet covered it well, but they talk about in this PARDD API functionality. So prior auth requirements, documentation, and decision. So I'm not sure how everybody's going to pronounce the acronym, but that's the new acronym. Allowing a provider to query the payer system to determine whether a prior auth was required for certain items and services and identify documentation requirements. Automate the compliance of necessary data for populating the HIPAA compliant prior authorization, and enable payers to provide the status of the prior auth request, including whether the request has been approved or denied, and then some additional things about the denial reason. And then it has to be populated with the payer's list of covered items, services, excluding drugs, for which the prior auth is required, and accompanied by any new documentation. And then a denial reason, irrespective of how that, this ... but how the denial was provided. So they still need to provide it even if the denial was done paper-based. So again, the implementation guides, Viet covered this really well, so I'm not going to go into deep dive, but again, the standards and the implementation guides were really called out. And again, I know they're suggestions, but many of us in the industry who have been tracking this, who have been participating in DaVinci, have been sort of moving along with the development of the IGs, right? To make sure that we understand how they work, that we're ready, because as Viet said, the benefit really is the standardization, right? That everybody is trying to do this in the same way, using the same set of standards, moving information with, although the workflows may be different on either ends, that sort of the middle part is very similar. And if you've implemented it once as a provider, you should be able to replicate what you've done with payer 1, with payer 2, with payer 3. And then again, there's a timeline for reporting those PA decisions. So impacted payers accept the QHPs on the FFVs, standard requests no later than 7 calendar days, expedited no later than 72 hours, although I know CMS is asking for comment on whether industry thinks they can do it faster. And then, the public reporting of the prior authorization metrics to public report annually, the metrics on their websites or via publicly accessible hyperlinks. And then they're separate for each item and service, not including drugs, and the data would be required to be publicly reported for each metric. And again, I am not going to read this. This will be shared with you, but it's a pretty long list of metrics. But again, the hope is that it will provide transparency. But I think payers and technology implementers need to think about this and think about, how are we going to track this? Are we tracking this now? Do we have a mechanism? Do we have the capability to collect this data so that it can be reported and shared in a public way? And that's all I had for for my presentation. So I'll stop sharing, and if there are questions, happy to take it.
Great. Thank you very much, Lynda. And you can see there's a lot of overlap with the two rules, but there's definitely some updating. So I think it'll be important for us. And thank you to CMS for including in the document itself the differences between the 2020 rule. I think that's made life a lot easier. I've not seen any questions, so I think we can move to Dan and talk about the freshly minted attachments rule. So Dan, thank you so much for joining us today, and thank you for your service on the WEDI board.
Well, thank you for having me. I know I was a bit of a late addition, so I appreciate the invitation. I do have some slides to share, so I will share those now. So again, thank you for having me. I know I was a late addition. What I intend to do today was go over some of the high-level points that were included in the recently released NPRM. I don't think there's anything in this presentation that isn't explained more fulsomely in the NPRM, so I would recommend everyone, if you want more information, please refer to that for the complete description of some of the topics I'm going to cover today. I will go through a little bit of a background and perhaps an introduction on exactly what caused us to release this NPRM, although I'm sure most of you in the industry are well aware. But there are a few interesting tidbits that come from the statute that affect how we think about attachments in HIPAA. And so I will cover that, and then I will cover some of the specifics of what we're proposing in the NPRM. I've included, just for everyone's reference, you know, I am from the government, so I do use a lot of acronyms. I presume most everyone is familiar with these, but they're here in the beginning for reference in case you are unsure what I'm speaking about once you have these in your hands. The first thing I wanted to talk about was first the original HIPAA law, and then the subsequent change that the Affordable Care Act made. And there's two important things in the original. The first is that when we talk about attachments under HIPAA, it identifies the attachment transaction as healthcare claim attachment or healthcare claim attachments. So that transaction is rather specifically entailed to support claims, at least under the original HIPAA legislation. The other thing I wanted to point out, under HIPAA, there was always a requirement to adopt a standard for electronic signatures. And in particular, we're going to be proposing a particular implementation specification to support electronic signatures on attachments. I'm sure everybody is aware that signatures and the order of operation and dating and the integrity of medical records is often one of the most significant issues, particularly when you start talking about medical records as other than clinical care documents, when you start talking about them as business records or perhaps legal documents. And then finally, and perhaps one of the biggest things that I'd like everyone to understand is that the Affordable Care Act requires the Secretary to adopt a standard for health claims attachments that is, quote, consistent with the X12 version 5010 transaction standards. And so Congress chose to give that direction to the Secretary. So that is one of the limitations we're working with for this proposed rule. So what we've chosen to do is expand the concept of health claims attachments to a broader healthcare attachment set of transactions, so that we can at least propose the same standard to support both healthcare claims in a HIPAA attachments in a HIPAA environment and prior authorization. In HIPAA, that's the referral, certification, and authorization transaction. Strictly speaking, that does require us to expand the definition as it was in HIPAA, but the Secretary does have the authority to at least propose that. Secondly, for those transactions, we're also going to propose a standard for electronic signatures, as well as a definition. And then as part of this, we're proposing to update the 278. At the time this was written and put forward, the 6020 was what we had to work with. I believe that may change some comments considering the current work going on at X12. And so we're adopting X12 implementation specifications to support the existing X12 adopted standards. That would be claims and prior authorization. And then we're proposing some HL7 implementation specification for the attachment information content, and then another guide for electronic signatures. Just as a general note, the concept of electronic signatures is the broad way to think about it, and we'll be proposing in the NPRM a specific technology standard. And so the first thing we had to do was clarify what exactly we're talking about that should go into an attachment. And so when we're talking about attachments, they're the things that carry attachment information. I know, right? It's very clever and innovative. We use the same word twice. But the point here is that for the two transactions that are already proposed in HIPAA, the attachment information would be defined as any information, not just clinical, that is required for payment or coverage determinations that is not already included in the X12 transaction. So the expectation would be one would only use an attachment if the implementation guides themselves don't contain the information that you need. And so we are in the NPRM. We go into a much more detailed discussion of the whys and wherefores for each one, but you can see we're proposing to update the 278, as well as adopt both flavors of the 275 and the 277. And then as far as the HL7 guides, you'll immediately note that we're still relying on the available and well-trod CCDA 2.1. Please, when you consider this, comment on the applicability and the correctness of this approach. The guides for the transaction specifications will be a little bit harder as you consider your comments. Always keep in the back of your mind, the secretary has to adopt something consistent with X12 5010 specifically. And then when we get to the electronic signature standard, we're proposing a definition of electronic signature, which is, I would have to say, substantially similar to already existing definitions of electronic signatures. However, we're specifically proposing to adopt the HL7 implementation guide for digital signatures to support the CCDA documents. So with that being said, it's also important to note that unlike other HIPAA transactions, when we adopt a new version in the standard approach of HIPAA, there's actually a set of 2 timeframes. Usually it's no more than 24 months for quote unquote large health plans and no more than 36 months for a compliance date for quote unquote small health plans. Because of the way the Affordable Care Act restructured the attachments requirements, we actually have a slightly different requirement. So the maximum is 24 months after the final rules effective date for covered entities. And so modifications give us a different ability for compliance dates. And generally that's not sooner than 180 days after the effective date of the rule. However, we didn't see any point in trying to move quickly to a new version of 278 when the rest of the updates wouldn't be coming along until much later. So because the secretary has discretion here, we've set the compliance date the same as the other implementation specification. And so we have many resources that are available, and I want to point everyone to our email updates service, and I'm going to place all of that in the comments here shortly after I'm done, so that everyone can have that link handy. In particular, because we are going to be holding 2 open listening sessions where we're going to again share this information, as well as perhaps go a little deeper into the NPRM on January 25th and February 8th. I do encourage you to join those as well. The information on how to register will be up on our website shortly at the CMS website, and will also be sent out via that email list. So I encourage everyone to sign up for those updates. And with that, that finishes my review of the NPRM. Rob, do we have a bunch of questions? I wasn't paying attention.
Do have some, and we've had sort of some conversation throughout the program. Terry and Heather in particular have been raising the issue of sort of how do the two rules harmonize with each other. For example, Heather says it's still not clear on how to resolve the CMS-PA NPRM versus the attachments rule on how to request specific data. The PA rule points to the PARD recommending the DTR. The attachment says to use the 278 to request additional information. So how do you see the two rules as being how can the industry harmonize these two rules?
Well, I think the best way to think about it is that there's a very specific definition of the prior authorization transaction in HIPAA. And so when you're working under that definition, you would need to use the HIPAA standard. Anything that doesn't meet that definition would not, and for which we haven't also adopted an implementation specification. So for example, eligibility lookup also has a very specific transaction definition. So you would need to use the HIPAA transactions where there's a specified, the HIPAA implementation specifications where there is a defined transaction that meets what you're doing.
And obviously, you touched on it briefly, but there's a lot of questions about what led to the selection of the 6020 version of the X12
Well,
to
so
78.
As we've been developing this process, originally, I'll be quite honest, we were looking at going with explicitly with 5010 because that's what Congress directed. But it's our understanding that there's a technical fault in the 275 in 5010. So that was the next available version. It's as simple as that. And so if commenters think there should be other versions, they can certainly submit that for our consideration.
And a question from our current board chair. I've been told the attachments rule appears to be missing section 162.2002F, the paragraph adopting electronic signature standards. Is this the case?
Well, I don't know. That's the first time anybody's brought it up with me. I'll have to review what got posted and get back to you.
Okay. And from Kathleen, if having to convey a detailed prior auth denial via 278 transactions, it has a character limitation of 264 characters, which may not allow for the detail needed. Is that something we should be commenting on?
I would expect so, yes. I mean, I can't comment on the utility of the fields in different versions at this time.
Gotcha. And I will say, on behalf of the industry, thank you, and thank you to Alex for the 90-day comment period. These are very complex rules, and I know there's going to be a lot of discussion and debate, and so the extra time is very much needed. David asks the question, how are other types of attachment types supported with the proposed rule that are not specified in the CCDA standard?
I think if you go into exactly how we're defining that, we're proposing that other sorts of, I'm not sure exactly what you're referring to, but so for example, things like legacy unstructured documents, video, imaging, are supported in the concept of the CDA unstructured, which is as part of what we're proposing. As far as the templates, there's some direction in the implementation specifications on how to create compliant templates for CDA documents in those guides.
Gotcha, good. Last chance to ask questions for our panelists. If you have a question for any of the other three as well. This is your opportunity to ask. You don't want to close if you have a question. Dylan has a question for the reporting regarding prior authorizations and the use of the API. Will they also consider / gather statistics regarding other electronic methods for requesting PAs, for example, such as online portals? Without that data, API usage may seem low, while electronic usage for prior auth using other electronic channels may be used. He points to the state of Washington already having regulations regarding the payer ability to provide an electronic capability to support PAs. Any thoughts on that? Really, it's directed to Alex.
Right. I'm afraid I can't comment on that one, Rob, but we could probably share that one with Alex's team.
Alex, I don't know if you have some thoughts on this one. She's still on mute.
I apologize. I had you on double mute. Do you mind repeating the question?
Yeah, let me pull it back up. So I guess the question is the metrics regarding use of the API. Is CMS also considering gathering other types of methods for requesting PAs, such as online portals? Because if you're only gathering one piece of information, it might not give you the full picture of what's going on in the industry.
And so specifically related to the prior authorization metrics that are publicly reported on a payer's website, those metrics will actually be reported for all of their prior authorizations, regardless of the mechanism used to submit. So yes, we are looking for that full picture, as you describe it, of the prior authorizations, not just the use of the API.
Gotcha. And would that be for pre-cert as well as referrals, or just pre-cert?
As well as referrals. I don't believe we go into that level of this distinction, and we talk about prior authorizations broadly. If there's something more specific that folks would like to clarify with that, I suggest submitting a comment on that particular point.
Appreciate that. Chris has a question for provider access.
Rob, if I could,
Sure.
I saw one from Kylie, I hope I'm pronouncing that correctly, a couple of times regarding signatures. And I wanted to clarify that the signature standard is required where the health plan's document requirements require a signature. So if you normally wouldn't require a signature on a document, then you wouldn't need to be utilizing that standard. But so documents that are already signed normally would begin using this standard for electronic submission of attachments. And then anything that you normally wouldn't sign or doesn't need to be signed as part of the process, since you didn't sign it, you don't have to use the standard.
Gotcha. Excellent. And Alex, a follow-up from Merrill. What about the metrics that providers are expected to report as part of their reporting through promoting interoperability?
So the data that's reported through the Promoting Interoperability program would be a tally of the unique number of prior authorizations submitted using the API and data from CERT. That would be tabulated within, likely within certified EHR technology as part of their reporting requirements. I'm not sure if there's something more specific about the type of data they're asking about, but it would be, it would be any of those prior authorizations done using the CERT.
Gotcha. Excellent. And for you, Alex, as well, for provider access, it is mentioned about being done for payers to work with in-network and contracted providers. What about providers on a leased network? Are those required to be included in exchange.
On a what network? I apologize.
A leased?
I can pull up the comment.
Yeah.
So we
Leased.
only talk about this as being for I see it here, a leased network. We only talk about this as being in-network provider. So again, if there's something, a further clarification that's needed on that point, I would suggest submitting that. I am not super familiar with leased network, so I'm not sure how that would be distinguished from being considered in-network.
And follow up from our good friend, Dr. Suarez. I'm still unclear as to why CMS did not allow an end-to-end fire solution to conduct prior authorization and still require the submitters to go from fire to X12 and back to fire.
So, I welcome Dan to chime in on this response as well. But to be a HIPAA compliant transaction, the X12278 is required unless, as Viet had mentioned, unless you have an exception for testing, which there is one that is approved for end-to-end fire, but that's not approved for all of industry. So the rest of industry needs to still include that X12278 to ensure that the transaction is HIPAA compliant. And I think that's really like all we can say on that. But that diagram does provide a little bit more detail, as well as the prior authorization support implementation guide provide a little bit more detail about that translation. And Dan, is there anything else that you would like to add for that piece?
I think all I would add is you're exactly correct, Alex. But I think it's worth noting and worth considering as you all are considering your comments. HIPAA, under HIPAA, the quote unquote standard is the implementation specification, or the implementation guide as it's sometimes called. So it's important to keep in mind that for a transaction under HIPAA, we only have the authority to adopt one implementation specification for each transaction. The secretary has the authority to adopt different implementation specifications for provider types, but it does not have the ability to have multiple implementation specifications just in general. And so if this is something that you'd like to comment on, consider what guide would be adopted to support prior authorization that would integrate with all of the other HIPAA transactions.
Excellent. That's, I think, an area where I think you'll probably receive a lot of comments.
Well, and if I could put in a little plug, Rob, I also expect to talk a little bit more broadly about this at the NCVHS committee meeting.
Excellent. Yeah, and I'll remind folks that's January 18 and 19. It'll be a 2-day hearing on the proposals from X12 and CAQH core. And Katie asked the question, I think I know the answer, which is 2 years, but was there a proposed effective date mentioned for attachments? I assume it'll be based on the publication of the final rule, correct, Dan?
Yeah, yes, just so. So the effective date is the short way to think about it is when we put out the final rule, at that point, we'll have an idea of the effective date. And so it would be 2 years after whatever that effective date is, depending on how long it takes to publish a final.
Gotcha. And Michael raises the issue last month at our member position advisory meeting. There was a lot of discussion around the supporting operating rules for attachments. And the thought was then that we would have to wait until we had a rule for attachments, and luckily that's come to fruition. So, Dan, I guess the question is, there may be some utility for moving ahead both with the rule and the supporting operating rules with the same cadence, as opposed to making one and then 2 or 3 years later going forward with the operating rules. Any thoughts in regards to harmonization?
I can say that I'm well aware that there are perhaps people changing their testimony to NCVHS as I speak. And it would be possible. And so if include that in your comments and explain the bonuses of doing that, please. And it is not out of bounds that that's a possibility when we go to final.
Oh, wonderful. I appreciate that. Last chance for folks to ask questions of these experts. And Michael, if we can pull up our last slide. And these types of events can't happen without our wonderful sponsors. So thank you very much to InterSystems and Lynda Rowe for underwriting this program and for being a very strong partner with WEDI. So I encourage you to check them out at their website. And I also wanted to thank our speakers, Alex, Viet, Lynda, and Dan, for their expertise and sharing their perspectives. This is only the beginning. There is going to be a lot of work for the industry to do. So I would encourage you to get involved with our work groups. We are going to be holding, as I said, member position advisory meetings on these rules. It'll give you a chance to share your perspectives and help shape the comments that WEDI will submit to the government. Again, I appreciate you attending this event. We wish you all wonderful, safe, and happy holidays, and we look forward to an exciting 2023. With that, I will close the program, and again, thank you all, and thank you to our speakers.